Stanford University.
How is your memory? Evaluating memory in the individual and its relationship to Alzheimer's disease. Did anybody have any problems with their memory? Okay, that was the right answer, actually. So we're going to talk about that, but the first thing is I have to talk to you about our advertisements, because this talk is not free. It's being brought to you by advertisements. So we're going to start off with our advertisements. And I work over at the VA hospital with the Stanford VA Aging Clinical Research Center, and we have several research projects going on. So we're going to start out by talking about what the definition of Alzheimer's and dementia is, so we at least have some terms we can work with. Then we're going to proceed into an advertisement, and then we're going to talk about some of the basic issues that I have that we need to be concerned about our memory difficulties and monitor them. And then we're going to talk about, we're going to give you a little bit of a game to play. And then we're going to go through a slideshow that's going to show you a whole bunch of either pretty pictures or gory pictures, depending on your perspective. And then we'll talk a little bit about what Alzheimer's disease is. And we really need to go pretty quickly until we get through the game. After that, I don't care if you interrupt me. I know she doesn't want you to, but that's up to you. So we're going to start by talking about what the definition of dementia is. So dementia is a specific medical term that refers to impaired memory and other thinking processes. So memory dysfunction is the #1 problem, and it's dementia when it's not just a memory problem, it's also associated with problems involving aphasia, apraxia, agnosia, executive function. Aphasia is difficulty, finding what words you want to use, and you'll find me having that just a few times tonight, hopefully. Apraxia is difficulty knowing how to do things, and agnosia is difficulty knowing what things are for. And executive function is making plans and organizing things. So, and it's not dementia unless it's sufficiently severe to interfere with your social and occupational functions. And the reason for this is you can have all these problems, but if you're functioning just fine, it's not considered dementia. Okay? And it has to represent a decline from a prior level, so it's not something that's been with you your whole life. So the problem was first described in 1907 by Alois Alzheimer, who was a psychiatrist and a neuropathologist that was managing a lady who was just 51 years old when she came in, and the complaint that she was having is that her husband was being unfaithful to her. And the husband was complaining that he'd been home the night before and he hadn't been unfaithful to her, and she just couldn't remember. So likely story, but anyway, she got progressively worse over time, was admitted to the hospital, went progressively downhill. Alois Alzheimer moved to another laboratory where he was actually studying brains with new stains that had just become available at that time. And when the lady died, one of the doctors that was taking care of her remembered that Dr. Alzheimer had been very interested in this particular case. And he arranged to have her brain taken out and shipped to him. And he looked at it under the microscope, and he found two major types of problems. There are several other things he found also, but the two major things that he found are known as senile plaques and neurofibrillary tangles. And he found these in the cortex of the brain, and this is now what we understand as Alzheimer's disease. Memory problems that progressively deteriorate to involve complete dysfunction, and it is accompanied, when looking at the brain tissue, by what we call neurofibrillary tangles and senile plaques. So that's pretty much Alzheimer's disease, and that now has stood for over 100 years. This is actually the picture of the lady. She had memory loss, disturbances of language, visual spatial deficits, difficulty with judgment, motivation, insight. She was depressed, anxious, sleep disturbance. She was psychotic, had delusions, paranoid delusions. And the thing is that what we understand now is that the actual anatomical circuitry of the brain explains these symptoms. The circuits of the brain that are affected by the plaques and the tangles explain why patients have these symptoms. That's how far we've gotten with our understanding. I'm not sure we've gotten much further, but that's where we are. So that now will answer the question about what is dementia, what is Alzheimer's disease. There are many different things that can cause dementia. What we say nowadays is about a third of the time when a person is demented, it's purely Alzheimer's. About a third of the time, it's purely not Alzheimer's disease. And about a third of the time, it's both. The likelihood of developing dementia and Alzheimer's disease increase markedly with age after about age 60. And the estimation is that there are over 5 million people in this country at this time with Alzheimer's disease. So it's a common problem. It's a desperate problem. It's a very severe problem. And now we're going into our advertisements. So you don't object, do you? So these are the sorts of studies that we're conducting over at the Stanford VA Aging Clinical Research Center. We work closely with the Department of Neurology over here, the Department of Psychiatry, and the Departments of Nuclear Medicine. We are conducting studies that are involving brain imaging. We are looking for ways to treat Alzheimer's disease immunologically, and I'll talk more about that later, but I'll show you our study. We have studies going on in memory and sleep, and we also are looking at a study involving agitation. Now, I've asked each of the people who are involved in one of these studies to prepare a slide for me. So I take no responsibility for the next 7 slides. Okay. This is the ADNI-GO study, and Michelle in the back of the room prepared this slide. And this is the Alzheimer's disease neuroimaging study. And this is an extension of the study. It's a very major study that has led to some major understandings of what Alzheimer's disease is and brain imaging. It's a study in which we have been following 800 individuals, 200 with mild Alzheimer's disease, 400 with what we call mild cognitive impairment, which is like they're not quite severe enough to be called demented, and then 200 normals. And we've been following them now for over 5 years. But we now have an extension of the study where we want to look at a particular brain imaging compound to try to see exactly what something called amyloid looks like in the distribution of the brain. And this is the ADNI-GO study. So this is a nationwide longitudinal study. We are looking for participants who will undergo both MRI and PET scans, also involving spinal fluid. And I'll talk about this later. One of the most important, some of the important advances we have in Alzheimer's disease, genetics, looking at spinal fluid. I know there's a rock band named Spinal Tap. You mustn't be disturbed by this. What does ADNI-GO stand for? Alzheimer's Disease Neuroimaging Initiative. I have no idea what GO stands for. Grand Opportunity. Oh, this is one of these this economic stimulus package grants. That's right. Sorry about that. So anyway, this particular study will last 18 months, involve 10 clinic visits. To be eligible, you must be between 55 and 90 years old. I don't see anybody quite that old in the audience yet, but must have be healthy and experiencing some memory problems and have a study partner. And Michelle can answer more questions. And I believe that all of these things, that there are actually handouts that you have in your brochure there. So there's more details there with phone numbers, so you don't have to write down the phone numbers. We have a study that we're working on with Bayer Pharmaceuticals from Germany. They also think they have a different compound that can image the amyloid in the brain. So the ADNI-GO study is looking at one compound. Bayer's got a competing compound. And we are looking for people who are 55 years and older and have had at least 6 years of education, that are completely healthy, or have a diagnosis of Alzheimer's disease, and they can lay flat in a scanner for imaging. And if you're interested in participating in this study, which is a competing study, but I'm pretty sure this only involves just one scan, you may contact Lindy Burton. The ICARA study, and this is something I will talk about a little bit later, is about an investigational drug where they're actually trying to develop an antibody to the amyloid that is the principal protein in the senile plaques of the brain. And in this study, we are going to be administering to people who have, let's see, 50 to 89 years old, and with you and your caregiver able and willing to give written informed consent, have a clinical diagnosis of probable Alzheimer's disease, and live with a caregiver and be fluent in English. And if you meet these criteria, there's an injection that will be given every 13 weeks for a little over a year. And during that time, we will be using yet another compound to image the amyloid in the brain called PIB. Somebody wants to know what things stand for. Pittsburgh Compound B. So this one involves a PIB antibody that we're doing with a PET scan, just the same as the last two ones I've talked about, but this time we're actually trying to treat Alzheimer's patients. And the preliminary results that have been found indicate that this infusion does decrease the amyloid in the brains of Alzheimer's patients. And I'm going to tell you a little story right now, just for a little bit of a comic break here. There are 4 major camps in the field of Alzheimer's disease. There are the people that believe that Alzheimer's disease is entirely related to a protein called beta amyloid. The senile plaques are made mostly of beta amyloid. The people that believe that this is the whole factor in Alzheimer's disease, and there's many of them, this is the dominant religion in Alzheimer's disease, are called Baptists. There's another group that believe that the neurofibrillary tangles are the most important thing in Alzheimer's disease. And the neurofibrillary tangles are made of a protein called microtubule associated protein tau. Do you know what religion they are? They're the Taoists. There's another group of people that believes that it's genetics that's really important, and that there's a gene called apolipoprotein E we'll talk about later. Is very much related to Alzheimer's disease. They believe that's the whole thing. They are the apostates. And the latest one is that there's actually a gene right next to that one that's called TOM40, and it's actually there's an axonal dendritic transport diathesis, and of course there's the atheists. So we've got 4 major camps in Alzheimer's disease, but the Baptists happen to believe that this particular study right here, and if we can just reduce the amyloid, will be stopping Alzheimer's disease. So that's why we're getting involved in this study, to see whether or not the Baptists are really right. Okay? We have another project where we're looking for to test memory in older adults, and this is designed to look at how mood and worry affect memory in older adults. I'm sure nobody in here has any problems with being moody or worried, but this test involves 4 hours of testing. And again, 1 year later, because we're very interested in this whole thing of seeing how people change over time. That's a big thing we're interested in. And they actually pay money for you to come in here. So if anybody's looking for some extra dollars in these hard economic times, call Sherry Boudreau. And you have to be 65 and older and interested in memory testing and have not been diagnosed with dementia. Like I said, somebody else prepared these slides. I take no responsibility for these slides being difficult to read, but you should have a handout that talks about this one. And this is Dr. Adamson is actually trying to understand how people can navigate in their everyday environments. And she is interested in finding healthy older adults from the population that can take what is actually a very interesting game, where they actually go around as if they're a taxi driver, and then she tests to see whether or not a person's able to remember what they've seen as they were sort of driving around this little gaming field. So if you're interested in playing video games and you're between 45 and 75 years of age with no prior strokes, I can use a pointer, is that right? Here, look at this. It's neat. No prior stroke, mental illness, major depression, or other neurological disorders, and have prior experience using a computer, you may please contact Dr. Adamson. We have another study involving sleep. You know that Stanford has major interest in sleep, and this particular study is a longitudinal study, so we're looking at people over time. We're looking for people who are 55 years and older with memory problems that are living at home and have a study partner. It's one of the things we have sometimes with these studies that's difficult is we require a study partner. We want somebody that can spy on you and tell the truth about how you're really doing. And what's involved here is sort of neat. Now let me see. Can you see this? This is a wristwatch here. See that? Okay, so the idea is to wear a wristwatch, and it's called an actigraph, and it keeps track of your movements 24 hours a day for several weeks, potentially. And they want to keep track of what your sleep-wake cycle is, and have you do some questionnaires and record the amount of time that you're spending in bed and out of bed at night. That's for 6 weeks. And if you're more interested in that, please call Daryl, who is at the back of the room, standing up in the green shirt there, at this phone number. And the last one is Jeff's study, and he's right here on the left. So if you have any, issues about his slide having print that's too small. You may talk with him about his study. This is the citalopram study for agitation Alzheimer's disease. And we've seen several patients who have Alzheimer's disease. One of the problems that we get as they get into their course is they develop agitation. And agitation includes restlessness, increased anxiety, short temper, increased difficulty concentrating, repetitive behaviors like rubbing the hands together for long periods or tugging on clothes or being fidgety, being uncooperative, being irritable, being stubborn. I'm sure no one here is stubborn. Shouting or cursing or rocking. So having these behaviors to a point where it's irritating the people around them, this is considered agitation. This is a 9-week study where we're trying this medication that is actually an antidepressant medication to see if it can improve behavior rather than some of these more sedating medications. And there has been some preliminary indication this is a good way to go. So if you're interested, call Jeff or Ellen Kim at that phone number. Okay, any questions on any of those? I'm not supposed to ask the questions yet, am I? Sorry. Yes, I'll take a question.
Which antidepressant are they using in that study?
Citalopram. Citalopram is also known as Alexa. There it is. Okay.
Did you give your name, or did I forget?
She gave my name. I'm Wes Ashford. And I didn't really introduce myself. Now that the advertisement's over, maybe I can sort of start my talk. Okay. Just like, advertisement, now we're going to my first major confession here is that I graduated from the University of California, Berkeley. I see an awful lot of red shirts in here. And I've been interested in Alzheimer's disease since about 1978. And so I've done a lot of studying in this area. I've been in Alzheimer's centers at UCLA, Southern Illinois University, UC Davis, University of Kentucky, and I've been here at Stanford for about 7 years. And I've published a lot in the field of Alzheimer's disease, and I'm the clinical editor for the Journal of Alzheimer's Disease, which at this point is publishing more papers in Alzheimer's disease than any other journal. So I have some understanding of this area, even though I'd say generally we have no understanding of what's really going on. One of the things that I believe is that we're not recognizing the people that have the problem. A lot of people, many people here have admitted they have a poor memory. Now, one of the things that we found is that the question, are you having difficulty with your memory, is one of the best questions for predicting in the next 5 years whether or not you'll develop Alzheimer's disease. The people who say yes are less likely to develop Alzheimer's disease in the next 5 years. Because with Alzheimer's disease, the first thing you do is forget you have a memory problem. I've seen well over 1,000 Alzheimer's patients, and what I always say when I first see them is, I say, how are you doing today? And then I say, what's the problem that brought you here to see me? And invariably, they'll say, this person here, because they never come in by themselves, I'll tell you that. Or they'll say, I'm here to see you about my knee or something like that. Well, that's interesting, okay. And then I say, well, have you been having any difficulty with your memory recently? And I get two answers, about half and half. One is no, and the other is no more than anybody else my age. And of course, the person that came with them, that literally dragged them in most cases, is pulling their hair out that somehow I'm going to be fooled into thinking there's no problem with their memory. If they told me they had a memory problem, I'd be asking them whether or not they were depressed. So now, as we understand the whole question of subjective memory more and more, we are recognizing that very early in the illness, people that are having a little more memory complaints than just the usual may be getting some early signs of Alzheimer's disease. So having a little bit of a memory problem might be troublesome for more than 5 years, 10 years, 15 years down the road. But by and large, once a person gets into the point of being demented, that they do not recognize that they have a memory problem. This is known as anosognosia. It's got a very fancy name, and it makes screening people, making early diagnoses very difficult because people want to cover up that they have a memory problem. They don't want to come in and face it. Just like you don't want to go see the dentist when you have a toothache. But this is even worse because you forget, that this is an important problem. So here's the problem, is that 90% of the cases of Alzheimer's disease are missed early, and even when you get to a nursing home, 25% of people with Alzheimer's disease are still being not diagnosed as having dementia. So I think that this is an important thing for us to recognize for a variety of different reasons. There are medications that are available that help memory. These medications seem to help slow down the progression. They decrease the behavior problems, which are very serious, and they seem to delay nursing home placement. So I think there's several excellent reasons for early diagnosis. If a person is having problems with memory that are significant, they are more susceptible to a variety of things like fraud and being taken advantage of. They may have problems with glasses. You need to recognize that they might have difficulty with driving. There's a danger issue. So I think these are all problems that need to be recognized. There's just a series of benefits in terms of, getting education for the caregivers, advanced planning, reducing the family stress, promoting safety, all these things. And I think it's the family's right to know as soon as possible that there's a memory problem that's significant. And there might be something that's treatable. That's a very important thing, is early diagnosis might lead to understand that maybe there's a B12 deficiency or a thyroid deficiency or a treatable brain tumor. There's a variety of treatable problems that can be recognized. Not a majority, probably less than 10 or 15%, but those are certainly cases that you want to recognize and see if you can reverse. And like I said, there are specific treatments that are available that seem to improve the course and seem to definitely improve the capability of the caregivers to manage the patients. I think there's no doubt that there's some modest benefit to the medications and the treatments that are available. So, my belief about Alzheimer's disease, it is quintessentially, I can use that with Stanford people here, can't I? It is quintessentially a disease of memory mechanisms in the brain. Whatever the disease process is, I believe it attacks the fundamental mechanism for laying down new information. And consequently, the best way to give a quick screening test to see if someone has a memory problem that might be Alzheimer's disease is to give a test that looks at ability to put new information into memory. Now, what happens when you put new information into memory is you have to form new connections between the neurons in the brain, called synapses. And it's that process of forming synapses where the beta amyloid and the tau are very active, and it's at that time that I believe the pathological process develops. But when that process is starting to develop early on, people are having significant difficulty learning new information. The most typical thing that I noticed first off is I'd ask somebody to remember 3 words. I've had many patients that I had this problem with, where I'd say, can you remember table, chair, stop? I say, okay, repeat them back to me a few times. Definitely, can you remember it? Absolutely, no problem. Let me change the subject for a few minutes. I go on and ask a few other things, and I'd come back less than 5 minutes later, and they had forgotten that I ever asked them to remember anything. And of course, I was a younger kid at that time with a much better memory, but I was rather shocked that people couldn't remember 3 things like that. And it turns out that remembering 3 things like that is one of the earliest symptoms of Alzheimer's disease. But at the same time, I was trying to do some work with monkeys and putting electrodes into monkey brains and trying to understand what memory mechanisms were. And we were trying to see how information went into memory. And we were looking at complex pictures. And we can also get monkeys to remember complex pictures, and it turns out that it's not just words that Alzheimer's patients can't remember for a few minutes, but they can't remember if you show them pictures for a few minutes. And then the question comes in, the typical test that we use for trying to detect Alzheimer's disease, we ask somebody to remember 10 words. And so we ask them to repeat them 5 times. And I don't know if you've ever had to try to remember 10 words and repeat them 5 times, but it's a pain. No one likes to do it twice. You usually do it once to humor the doctor, but that's it. But on the other hand, if we can develop something that's fun and easy and enjoyable to do, we've had no problem with this. And so that's what we're going to show you here. So we also think that by showing pictures, we can develop a much more precise and reliable way to improve our sensitivity and specificity. And as we thought about this, we discovered that actually we could test a whole audience like this in 5 minutes. So I'm going to test all your memories right now, and we'll see how you do. So what we're going to do is we're going to show you some pictures that are complex pictures that are relatively easy to remember. We're going to, we still have a long way to go before I really think this is going to be useful for, taking out to the general public. And so what we're doing tonight is really just sort of a game to show you the sort of memory problems that Alzheimer's patients have. And I don't want to be held to the reliability and precision of the grades that we might give you back if you so choose. But picture memory is less affected by education. We can easily test it by computer. You can take the same test. We have it set up on the internet so you can take it. And we think that by using different sets of slides, we can see how people's memories change over time. And it's fun, so you'll do it again.
Don't you think that some people have better visual memory than others, and that would make a difference?
Absolutely, and so it's better if you take it over time and see if it changes. Now, what I'm going to have you do, I'm going to read these directions to you. So when we show you pictures, I want you to carefully look at each picture. If you see a picture that you have seen before, mark the circle next to the number of the repeat picture. For the main test, you'll see 50 pictures. Each picture is numbered. The pictures will stay on the screen for 5 seconds. There are 25 pictures that are new and 25 pictures that are repeated. Now, it turns out we've already given this test to probably well over 2,000 people, and it turns out that about 1 in 10 people has no idea what I just tried to explain. So if you don't understand what I'm saying, we have a practice test, so we give 10 pictures to try and get you to have an idea of what we're talking about. Okay, the pictures are going to for the most part, it's going to be pretty obvious whether you saw them before or not, and I'm going to show you at the end to convince you of that. There's a couple in there that are pretty tricky, so you do have to look. But once you see them, it's pretty obvious that they're the same or not. Okay? You ready to try the practice? Ready? Set. Up. Okay. Go. Okay. You should have marked your answer sheets under practice test just like that. Did everybody get 100%? Good. Okay. The results you get on this test, if you fail this test, you are not going to get reported to the Department of Motor Vehicles unless you put your name on the test. So I recommend you don't put your name on the test. People in the back will probably not see the pictures quite as well as the people in the front. And what I'm really doing is I'm showing you the sort of problems that people with Alzheimer's disease have with their memory. And at the same time, I'm doing a major job of teasing the audience with this whole thing. But don't consider this to be an accurate, precise memory test. But it is a good game. Okay? All right, enough of your questions. Let's go. Ready? Go. All right, and stop. No changing any of your answers. Now, what I'm going to ask you to do is hand this answer sheet, to the sides? To the middle. To the middle. And I'm going to have Emily and Michelle and Daryl and Jeff will be collecting these. But one thing you can just note and be sure is that the number that's on the thing that says answer sheet is the exact same as the thing that says memory screening results. That number is the same, and so what we're going to do later on, they're going to go to the back and score these. We don't have electronic scoring yet. It takes them a few minutes to score these things. And they'll score it for you, and they'll give you your answer back, but they'll only give you your answer when you show up with a sheet that's got the exact same number as on your answer sheet. Okay? I think in Alzheimer's disease, the problem is taking in and absorbing the information, not the recognition of it later. So actually what you're doing is by being able to see whether or not you recognize it, you're really trying to test not so much the recognition aspect, but whether or not the information was put in the first place. So that's really what we're trying to do here, is see how well the information was put into your memory. And the thing is, you may not have had any problems with this, and I would suspect that most people in this room had no problems with this. But patients with Alzheimer's disease, patients with mild cognitive impairment get less than 80% correct. And people, once they get into the mild dementia range, get less than 70% correct. They make, more than 30% errors on this. And once you get into being moderately dementia, it's random. They can't remember seeing the pictures before. It's a very striking loss of the specific mechanisms related to Alzheimer's disease that leads to failure on this test. So most people take this test and say, well, that was silly, that was easy. But the people that have significant memory problems have substantial difficulty with this test. Now, I'm going to go through these things, but they want me to go through these things with a pointer here. So everybody can see this pointer up here, where I'm pointing? Everybody see that? What is that? The wooden ladle, right? Okay, what is this? The yellow truck. Okay, what is this?
Darning egg.
I wonder if that's true. I think somebody told me it was an African musical instrument, but maybe it is a darning aid. It could be. Okay. How about this? What's this? Okay, what is this? That's a repeat. Okay, that's a repeat. What is this? The trick. Aha, she caught me. Okay, this is a different basket. Uh-oh, excuse me. Okay, sorry. Let's see, where are we here? Okay, what is this? Light on a roof. And what is this? A Tyrolean hat? And what is this? Okay, repeat. And what is this? Okay, that is a repeat. And what is this? Repeat. And this? Good. And this? An orange tractor. Okay. And this? Pizza cutter. And this? Egg beater. And this? Repeat. Another tractor. Okay. And what is this? Pack on the side of a barn. And what is this? Grader. And this? A repeat. And what is this? And this? Hat. And what is this? Decoy. And this? Repeat. And what is this? Machinery. Okay, what is this? Repeat. And this? Repeat. And this? Hand truck. And this? Creamer. And this? Repeat. And this? Repeat. Repeat. Different hat than the other hat that you'd seen twice before. Here? Some sort of tea cozy or something. Repeat. New hat. Window side of a barn. Repeat. 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 Kerosene lantern. Okay. Repeat. Repeat. Tongs. Repeat. Repeat. New tractor. Okay, and then let's see. Where's my arrow here? My arrow's gone. Where'd my arrow go? Here we go. Okay, repeat, repeat, repeat. Okay, is that okay? Now, one of the things that we did, and we've done a lot more subjects than just 116, but in 116 we looked at the beginning, we found that for number 33, that we had, let's see, what is 33? This hat? 64% of people got this wrong. Number 6, 58% got this wrong. Number 47, 27% got this wrong. And then there was a few others that people got wrong too. Number 35, 33% did not recognize this as something they'd seen before. And number 27, which is attack on the side of the barn, 20% didn't recognize that. And number 5, looked like about 16% didn't get this, and usually the people that weren't paying attention at the beginning. Okay, so that's how that works. And so
The two with the duck, that the second duck was turned, that the first duck was actually turned a different direction.
but when I showed you, it wasn't true, was it?
It wasn't true.
Wasn't true. Okay. So the thing is that only 8% of people had a perfect score. 23% made one error, and almost 70% made 5 or fewer errors. So most people make 5 or fewer errors, which gives you a 90% correct. Then there's a few people that make between 80 and 80%, and the thing is some people don't have a good day and might have some problems. If you're making more than 80%, or less than 80% correct, and that's making more than 10 errors, which was 18% of the sample that we've looked at, then the question is there a problem? And I'm not saying that anybody who scored less than 80% has a real problem, but it is something to consider, and whether or not this would be something to discuss with your doctor the next time you saw him. He's asking if he put his name on the paper, at what level would I actually report him to the Department of Motor Vehicles? And the thing is that I was really kidding. I'm really not going to report the Department of Vehicles. Just trying to keep this thing anonymous so that we don't get in trouble with the IRB. That's a major concern I have. But if you went to your doctor and you were concerned about your memory, you went and saw your doctor said, I think you might have Alzheimer's disease. Your doctor would, by state law, be required to report you to the local county health department, who will in turn report you to the Department of Motor Vehicles. So that's what the law is in the state. And your doctor, if he thinks you've got Alzheimer's disease, is required to do that. Sir. So the thing is, so we looked at people. The one thing that we have found is that as people get older, they don't do as well, both in terms of the false positives and in terms of the false negatives. Not a big difference between the men and the women. And when we looked at it in terms of education, actually the more education you had, the less well you did. And this all goes back to what the Greeks thought is, if you learn how to read, it's going to ruin your memory. So it's entirely true based on what we've had. And the test is online. We have metafile.com, memtrax.net. We're working on one memtrax.com right now. We're trying to figure out how to get this out so that people can take it in some sort of reliable way and establish. We're actually working with a Blueberry study right now where they're trying this on people who are taking it two versions of the test a day for 5 days in a week for 2 weeks in a row. So we're actually trying to get this to a point where we can understand what its performance is, but it seems to be a very robust test, and it's simple and fun to take, which is very different than a lot of the other ones. Now, I'm going to go through one question, then we're going to jump to a whole bunch of other slides. Sure. Well, let me comment. He's asking about the difference between remembering verbal memories, remembering conversations, and remembering different things. And here's the way I believe that memory works. Is when new information comes in, it basically goes into this complex neural network that you have in your brain. And the neural network adapts to it. Anybody have any idea about how many neurons there are in the brain? Zillions? Is that what I heard? Zillions. 60 billion. 60 billion is pretty good. I mean, I've heard 100 billion, but 60 billion may be a more modern concept. So let's just say it's 100 billion, okay? Approximately, give or take a few. Each neuron has a cell body, and it has processes called dendrites that come down into it, and then it has an axon that comes out. And information comes in through the dendrites, through synapses, little places where axons touch them, or different sensory organisms, come into the dendrite, processed in the cell body, and at some point, something here called the axon hillock, right where the axon begins, there's a decision made as to whether or not the information has reached a critical threshold, at which point an action potential is fired, sending a single bit of information down the axon, which goes over to another neuron, to the dendrites. Now, the question is, how many times is there a connection then from an axon over to dendrites here? And it turns out that neurons have on the order of 10,000 inputs on the average. It can be much more, it can be less, but around 10,000 inputs. So if you have 100 billion neurons with 10,000 inputs in each neuron, how many total synapses are in the brain? A lot. 10,000, you have 10,000 connections, synapses, where there's a connection between this neuron and this neuron in the brain. So you've got 100 billion neurons, and each neuron's got 10,000 connections. How many total connections are there? A quadrillion. 100 billion times 10,000 is a quadrillion. If you're not careful, I'll tell you the joke about it is Brazilian, but a lot. Suffice it to say, there's a lot of connections. The thing is that these are not static connections. There are constantly new connections being formed every time you learn new information. Constantly forming, literally billions of new connections are formed every minute as you're learning new information. At the same time, billions of old synapses that aren't quite the right way to see the world are being lost. Your neurons and the connections that they're making with each other are constantly being remodeled when you're learning new things. That is the process that's being disturbed in Alzheimer's disease. Your earliest memories are in this network of connections. And you can recognize things that you've seen many years before because of the incredible power of this network. But as Alzheimer's disease progresses, you lose the capacity to form the new connections, and the old connections deteriorate, and the axon processes of those neurons are attacked by the Alzheimer process and are lost. So initially, you can't form new memories, whether it's verbal memories or nonverbal memories, and it's different for different people. But it's later on as the disease progresses that you can't learn, that you don't remember old information, because as the connections, the old connections are being destroyed because you can't form proper new ones, the old memories are being dragged down. So early on in the disease, people have no difficulty remembering things that happened in the distant past. As the disease progresses, they're no longer able to remember those things from the distant past. Does that answer the question? Okay? Yeah. But sometimes what happens is they'll start thinking that one of their children is one of their parents, because they won't quite have the accuracy of recollection, and they'll be recollecting that their child actually looks the way that their mother looked when they were a little kid, which is sometimes a little bit true. Anyway, so what happens then is that the brain goes from this normal appearing thing here on the left and starts atrophying into this thing more like what's on the right. And so I'm going to take you quickly through a slideshow showing you a bunch of these things. Here is some pictures of normal brains here, a normal brain showing you, if you look, this is the way it looks like on the side from the left, and then you start cutting it right down the center from the, like so. You can see that there are some spaces in the brain where there are fluid, but they're pretty small. When you go into moderate Alzheimer's disease, you start seeing the shrinkage in the cortex, and you start seeing there's an enlargement of these water cavities here in the brain, and particularly enlargement of a little area here called the temporal horn, which is an indication that a very important little structure for remembering new things called the hippocampus right here is shrinking. One of the most reliable things that we see in Alzheimer's disease early on is the shrinkage of this area right here called the hippocampus. And as it progresses to severe dementia, we see these fluid spaces increasing as the brain itself is shrinking, and this area here, it becomes just a little wisp of it left of the hippocampus. And the hippocampus is absolutely essential in forming new memories. And as that is being lost, you're not able to form the new memories. Shows you a side-by-side comparison.
Can you point out where the hippocampus is on the healthy side?
Okay, so this whole little fat thing here is the hippocampus, this whole structure. And here on the other side, this little thing here. You see the way this space here, this is a fluid space here that's greatly enlarged. Okay?
Question. Is that information only available once you're dead?
Well, we have ways of very accurately diagnosing Alzheimer's disease. We can take a person and we can take their brain out and put it on a table, and cut it up like this, look at it under a microscope. And then when we finish, we put it back together with special glue and put it back inside their head, and they never know anything's happened. Now,
In a functional MRI, don't they take slices?
okay, you're jumping ahead because we're going to talk about brain imaging as soon as, but I want to show you the real stuff first before we show you brain imaging. This is a slide that's just something you might see under a microscope with special stains. And this was the sort of thing that Alois Alzheimer found in 1907 when we looked under the microscope. And what we see here are neurofibrillary tangles and senile plaques. And they are generally mixed together like this, although not in all places just so. These black things here are the neurofibrillary tangles. And these orange things here are the senile plaques. The orange is a special stain for the substance called amyloid. But I want to point out that these amyloid plaques have black fibers in them. In fact, it looks like somebody spilled lint on this slide. And look at all this little lint that we see in here, all these little strings in here. These are called neuropil threads. Turns out these are connected back to through the dendrites back to cell bodies. And some of them even seem to be invading the senile plaques. There is an interaction there that we do not understand, but there's clearly dynamic processes going on. Let's see. This is again a neurofibrillary tangle here, and you can see that the amyloid core even has this inflammatory surround to this compacted core. Again, neurofibrillary tangles, and then the amyloid that's in areas not necessarily directly around the neurofibrillary tangles, but can be associated with this these black threads are called that we call neuropil threads. They're made of the same substance here, which is the hyperphosphorylated tau protein. So the beta amyloid protein here and the tau protein is hyperphosphorylated is here.
Doctor, how big are those?
So one of these neurons can easily be 50 to 100 microns across, and those plaques that right there could be, say, 100 to 200 microns across. Okay? They don't occur randomly throughout the brain. They occur in special regions of the brain. And if you look at the brain on the side, you'll see that here's one of the earlier findings here, discovered that actually they are represented here in a rather distinct area in what's known as the posterior temporal lobe. So this is the temporal lobe of the brain, and this is the posterior temporal lobe. So we find them here, and this is the parietal cortex, and we find them in what we call the inferior parietal cortex here. We do not find them very much in the occipital cortex where primary vision is. We don't see them in the somatic or motor sensory regions, the primary regions here. They're relatively clean here. And we only see a small amount early on in the disease in the frontal lobes. This is very specifically a disease of the posterior temporal and inferior parietal lobes. It is not a random disease throughout the brain. It affects specific areas. The important thing is that these are the areas that are responsible for learning new information and storing new information. And particularly in this area for visual information, and here auditory information. More language on the left, more visual spatial on the right. But this explains the sort of thing. Whether you look at neurofibrillary tangles or the plaques, you can see that the neurofibrillary tangles have a more discrete distribution than the neuritic plaques do. And here's where the problem comes in, that the neuritic plaques, which are made of the beta amyloid, don't have as tight a distribution with a specific pattern as the neurofibrillary tangles do that are made of the tau. In fact, the neurofibrillary tangles have a much closer relationship to dementia. The tau pathology has much closer relationship to dementia than the amyloid pathology does. And this has been the big confusion in the field, is what is more important, the amyloid or the tau? So while the tau pathology is more closely related to the dementia, the loss of memory, the loss of other cognitive functions, the plaques that are made of the amyloid has a more close relationship with known genetic factors related to Alzheimer's disease. So this is the big difference between the Taoists and the Baptists. It's a critical issue for us to understand. A couple named Brock, Heiko and Eva Brock, went through literally thousands of brains and stained them and looked to see what the distribution of the pathology was, and they defined a particular staging system, 1 through 6. And so 0 would be no pathology, and if you have just a little bit of this little brown stuff right here in what's called the entorhinal transition area and hippocampus, they call this stage 1. Stage 2, it goes on a little further here. Stage 3, it expands out to fully involve the hippocampus and start involving another area of the cortex down here. But it's not till stage 4 that it starts involving out here to the rest of the cortex. Stage 5, it starts involving much broader regions of the cortex. And in stage 6, it involves very large regions of the cortex throughout the brain with a few specific exceptions, such as this primary visual area here. So the thing is that the Alzheimer's pathology is not random, it's not nonspecific, it follows a very specific pattern of where it attacks first and how it spreads throughout the brain. So we understand this is a very specific disease process. This can take this problem early on, may take several years, may take 10 years to go from stage 1 to stage 3. We call this a point when people are having difficulties with their memory, because this is very much an area that's involved in forming new memories. And once you start involving this area out here, the old memories then are getting destroyed as well. And once you get into these phases here, this is the areas where old memories are being destroyed. So it's not a non-specific disease. It's very specific patterns. And this is, again, just sort of a cartoon where they went through and showed the specific regions of how they looked at all the different brains and saw how it progressed at different stages. And the neurofibrillary tangles have one particular pattern, and the amyloid has a different pattern that's much broader and not so specific. So this has been studied in extensive detail. Now, one of the things that we try to do is try to look at those, the particular neuropil threads, and this is a study that I did back in the 1990s, where we actually were able to look at what these would be like the neuropil threads that I showed you on that prior slide, and this would be like one of the neurofibrillary tangles. And what we found is actually that there were connections that you could follow these brown stains back through normal dendrites all the way back to cell bodies. So it turned out that what's actually happening is that somewhere out here in the cell body that is connected, somewhere in this dendrite that's connected back to the cell body, there are problems developing with the tau pathology. And there's something we think then that is in this transport mechanism, because there's constantly being material transported back and forth, that this tau gets what they call hyperphosphorylated, and it clogs the process. And in the process of clogging the process, it kills, it basically amputates everything that is out distant to that. So if you have a dendrite like this, and you get a clog right here, then all of this gets lost. And that's where your old memories go. So first you can't form new memories, and then later all those old memories are lost. So we're actually tracing the actual pathology that's developing. Many different neurons are involved in this. Acetylcholine, not dopamine, but serotonin, norepinephrine neurons are involved. Glutamate neurons are involved in the cortexes. There's different groups of neurons that are involved, and other neurons that are not involved. So it's not a non-specific disease. It affects certain types of neurons and in specific regions of the brain. And you can't just explain this disease very simply and like it just affects a certain type of neuron, because it affects It affects the neurons. They're very much involved in forming new memories. Now, so the question then came, if you can understand this in patients who have a problem, can we use brain scanning techniques to really see what's happening inside the brains of the living patients, to see if we couldn't follow this progression? And so there have been many different brain scanning techniques that have been developed. The first thing came along was computed tomography, CT scans, MRI scans came along, volumetric MRI scans where we could actually measure the hippocampus, measure the size of the brain, and show how it was declining over time. We found functional MRI scans. We've done PET scans. We've done PET scans that involve metabolism, where there's very specific patterns of loss of metabolism. And now we've gotten into the actual amyloid imaging that I mentioned at the beginning, because we're actually doing amyloid imaging here at Stanford. So I'll show you some of these different techniques that we've used. So this is the MRI scan. So you see, just like I was able to show you a brain before that had been cut, now you can actually look in the living person. And you can see exactly what I showed you before, where the normal brain has these relatively small fluid spaces, and the Alzheimer patient then has these relatively large fluid spaces with loss of the hippocampal volume. So now we can make these, we can see these in the living patient and we can measure them. We can look at blood flow. And this is the way the brain usually looks in terms of on a SPECT scan, with normal blood flow. And here is a view of the brain from the left side, another patient, another normal individual, from the top, and from the right side. And this actually is a person who had a little bit of memory problems, but nothing significant. A near normal scan, but it wasn't quite normal because it looks like there's some decreased activity here and up in here, getting into mild dementia, where there's actually, we're seeing some decreases of blood flow in the brain. As it's progressing into mild to moderate patients, we see progressively less blood flow, particularly here in, like I said, the inferior parietal region, and you get into the moderate area, we start seeing a tremendous shrinkage of the amount of blood flow that's going into the temporal lobes. We go into the severe cases, it's substantially more. In the profound cases, there's huge areas of the brain that are just not getting adequate blood flow. We graded these things. We can look at, see what the duration is. You can estimate how many years they are into the illness with this sort of gradation. And we made some analyses with computers to try and take this here a normal, and we would take a normal brain and try and put it into a standard matrix so we could analyze it, a person with severe dementia, and put into a standard matrix. And we did analyses versus the severity of the dementia. And we were able to see that there is decrease of blood flow essentially in exactly the same areas of the brain on both the left side and the right side, where you see most of the neuropathology of the Alzheimer patient at autopsy. So the areas of the brain that correspond to the areas affected in the patient, you can see right here on the blood flow. And you can see here in the primary motor cortex and sensory cortex, and even back here in the occipital cortex, I'm not showing the medial side, which shows this dramatically, that it is literally the same pattern of progression that we see in the living patients that is seen when you look at a cross-section of a whole number of autopsy series. So we can see the progression in the living patient with the blood flow measures. And we can see them on PET scans. This is, now I'm not going to go through this in detail, but you basically see the same pattern going from mild, normal, moderate, severe, profound. See the same pattern when we're looking at metabolism rather than blood flow. So the patterns of progression that we see at the autopsy are the same patterns that we can see with both blood flow and metabolism evaluations. Now here's a very interesting study. We're going to get into discussing the genetics of this, because what you see here in the purple is a particular scanning technique where they're able to show in the purple areas that had decreased flow in patients with Alzheimer's disease. But the areas that are in blue here turn out to be areas that are abnormal in patients that have something called the apolipoprotein E4 genotype. It turns out, at least this is my belief, that one of the most important things that we have in Alzheimer's disease is a genetic story. And it turns out that the clearest genetic story, we have some very clear genetic stories. For instance, Down syndrome cases, which have an excess of the amyloid preprotein gene. They produce 50% too much of the amyloid preprotein gene. Inevitably develop Alzheimer's disease by 40 years of age. So this is one of the additional curses of Down syndrome. And it's clearly related to the amyloid preprotein. It turns out that there are some other rare cases of a specific mutation in the same protein that are associated with the development of Alzheimer's disease in the 40s and 50s. Tragic cases. But those represent probably less than 2% of all the Alzheimer's cases. Very interesting molecular biology, understanding all the chemistry involved, very interesting, but they don't explain the disease as a whole that affects mostly people who are in their 60s, 70s, and 80s. Now, here's the numbers. At age 62, you have 1 in 1,000 chance, that 1 year of your life, of developing Alzheimer's disease. The number doubles every 5 years, so that by age 78, you have a 1 in 100 chance of developing Alzheimer's disease that 1 year of your life. And then by the time you get to 94, that 1 year in your life, it's 1 in 10. It seems to flatten out after that, but there's this tremendous increase from 60 to 90 years of age. And this number is very much affected by the apolipoprotein E genotype. Now there are 3 different genotypes. There's the 2, there's the 3, and the 4 alleles. And that means since everybody has 2 alleles, you can have a 2-2, a 2-3, or a 2-4, or a 3-3, or a 3-4, or a 4-4. So almost everybody in this room has one of those 6 different genotypes. Now it turns out that in a group of normal individuals, that about 60% have the ApoE33. And the people with the ApoE33 have about 1/2 the chance of developing Alzheimer's disease as the ones that have, as just the normal population. They account for about 60% of the population, accounts for about 35% of the patients. It's about a half. The ones who have a 3-4, which are 20% of the normal population, Caucasian population, these numbers are about half in Asian populations. But of the 3-4s, about 20% of the normal population has the 3-4 genotype. And they represent about 40% of the Alzheimer's cases. So if you have a 3-4 genotype, you have twice the chance of getting Alzheimer's disease. If you have a 4-4, which is about 2% of the population, 1 person in 50, you have about a 10-fold increase of chance of getting Alzheimer's disease. And here's the way it goes. That the 4-4s have an average age of onset of about 67 years old. The 3-4s have an average age of onset of 76 years old, and the 3-3s have an average age of onset of 85 years old. And it turns out the ones with a 2-3 probably don't have an average age of onset until about 95. And the 2-2s, a lot of them make it into the hundreds. And a lot of people in their 90s and 100s that have no memory problems are people much more likely that have one of those 2 alleles. So the thing is that your exact ApoE genotype has a tremendous effect on your chance of getting Alzheimer's disease if you live long enough. Actually, we found a very good way of preventing Alzheimer's disease. Smoking cigarettes. Each pack of cigarettes you smoke per day can decrease your life expectancy by about 5 years. And if you can smoke 2 packs of cigarettes a day and die young enough, it really decreases your chance of getting Alzheimer's. It's been extensively studied and shown. But the thing is that if you happen to have this 3-4 or the 4-4, already in a younger individual with no memory problems, we can see on this slide where that blue is, where you can see where the apolipoprotein E is already affecting the brain early on. Now, we have another scanning technique. We have PET scanning, which I've shown you already with the normal, what we call FDG, shows metabolism and shows the very specific regions of the brain that have decreased activity. There's a substance called FDDNP that was developed down at UCLA where you can actually see where the plaques and tangles are in the brain. Not just shrinkage, decreased metabolism, decreased blood flow, but we can actually see the areas where the plaques are developing, where the tangles are developing. And there's another compound, PID, that I mentioned before, where we can actually see, in Alzheimer's cases, we can actually see where the amyloid is depositing. Now, the amyloid deposits, where you see here in the bright colors, don't follow the pathology quite as well as the tau does. So, on the one hand, the amyloid is more related to the likelihood of getting Alzheimer's disease, but the dementia itself is related to the tau pathology. So there is an interaction there that is critical for understanding. So this is where the amyloid plaque is deposited and where the PIB is shown. And to show you that there's a relationship with how Brock showed where the amyloid changes were. And this is just a little fancy stuff to show you here. So this is showing you the PIB scanning and showing you where the amyloid is on a PIB scan. Oops, wait a minute, it's supposed to turn. Oh, you know what? I'm sorry, it's not going to turn because I didn't bring the turns. We're using this computer. It's on my computer. Sorry. It looks neat when it turns, but it's not going to turn for you tonight. Sorry. Okay. We use something called the mini mental state exam. And it's an old test developed in 1975, and we don't think it's a good test to use. It's old-fashioned, but it's been widely used, and it is pretty good for giving some general idea about how impaired a person is. Now, a mini mental state score, a perfect score, is 30, and you have questions like, what's the date today? What year is it? What season is it? What's the month? Remember 3 things. Count backwards from 100 by 7. Tell me what a watch is. Tell me what a pen is. Do a little drawing for me. Repeat no ifs, ands, or buts. There's a whole little thing that's done in the mini mental state exam, and then you add up the points, and a perfect score is 30. Now, we define a person who gets a score of 24 or below as having dementia. Now, the number is very crude because you can have people who have a score of 24 that are not demented. You can have a person with a score of actually as low as even 22 and not be demented. They might have poor education or something, might have some other problem. And we have people who score 30 that they're already in the early stages of dementia, particularly some of the Stanford professors around here. They score very high on this, but we know there's something the matter. So here's the thing, is that we looked at the time course here. And you can see the time course, if you call 24 a 0, that it takes about 8 years to go from a score of 0 down to a score of 1. And a person can still live for years after this if they get a feeding tube and they're taken care of and lying in a bed. Because Alzheimer's disease doesn't really kill you, it just decreases your chances of driving safely. But the thing is that we can actually measure for 6 to 8 years before this that people are starting to go downhill slowly, and this is variously called things like mild cognitive impairment, age-associated memory impairment, early Alzheimer's disease. We believe that the pathology is progressing during this period of time, and it is serious. And that while the Alzheimer's incidence is increasing with age, and this is showing you, of a percentage of a population, the percentage that has Alzheimer's disease, there's an equal percentage of people that have mild cognitive impairment. And by the time you get to 85 years old, most people are having some problem. It's only the people who are really of a particular genotype that are being spared from this. So let's talk about the risk factors. Apolipoprotein E is by far the biggest risk factor. And the problem we have in this country, I think to a large extent, is the O.J. Simpson syndrome. Everybody wants to see if the glove fits. They don't want to pay attention to the DNA evidence. But it's the DNA, it's the genetic evidence that really tells the story here. Family history is important. Family history of Down syndrome is even important, and Parkinson's disease. Turns out things like obesity can increase your chance of getting Alzheimer's disease by about 3.6-fold. Now I said that a 4-4 versus a 3-3, there was about a 20-fold difference. So 3.6 isn't a very big difference. But the maternal age is a factor. Head trauma with loss of consciousness increases your chance of developing dementia later on. A history of depression does as well. Hypothyroidism, not quite clear if it's totally significant. There's been some question here. People who have severe headaches seem to have less of an incidence of Alzheimer's disease. People who take statin medications, appear to have less Alzheimer's disease. This has not been shown to be beneficial as a treatment for Alzheimer's disease, but it may be that it's that early mild cognitive impairment that you've got to start very early for the statins really to have this effect to decrease the risk. People who take non-steroidal anti-inflammatory drugs may have as much as an 80% decreased risk of Alzheimer's disease. But again, only if they've taken it for many years, and then the question is it like smoking? Because sometimes these things you don't know if it's preventing the disease or if it's causing people to die early so they don't get the disease in the first place. So until we really explore these things further, we don't know that these are definite. We're not recommending that anybody go out and start taking NSAIDs or statin medications to prevent Alzheimer's disease. What we are recommending, and it is in your handout, we're recommending a healthy lifestyle. And the NIH has just recently conducted a major consensus panel trying to determine whether or not they thought there was anything that was associated really with a decreased chance of getting Alzheimer's disease. And the consensus was that there is nothing that they can say for sure is going to decrease your risk of getting Alzheimer's disease. Not a single thing up here can you modify and know for sure that you're going to decrease your risk of getting Alzheimer's disease. On the other hand, there's probably a lot of healthy living things that you probably can do that may decrease your chance of getting stroke and might decrease your chance of getting Alzheimer's disease. So you should definitely discuss, what the best things to do are with your doctor and take good care of yourself. I've already talked about this a little bit, about how mortality increases with age and how Alzheimer's disease increases with age. And this is just showing you what I already told you about the ApoE genotype, that it increases the risk with age. And when you're looking at people who are under 70 years old that have Alzheimer's, a large portion of them have the E4 gene. Women, as it turns out, have about twice as much Alzheimer's disease as men. Maybe more. But you can account for at least twice as much just because women live longer than men do. So I'm not sure that's of any benefit to the men. The problem in the future, people are growing older. In the last 160 years, life expectancy has increased by nearly 40 years. I said every time you increase life expectancy by 5 years, you're going to double the amount of Alzheimer's disease. And so that means if you can increase life expectancy by 5 years about every 20 years, every 20 years you're going to get a doubling in the number of people that have Alzheimer's disease. And as the baby boomers crest later on in the century, we're going to get tremendous numbers of people that have Alzheimer's disease. So we desperately feel there's a need to find out what it is and how we can prevent it. Let me see. We've still got a little time left. I'm going to tell you a little story that came out of the ADNI study. That's Alzheimer's disease neuroimaging study. One of the things that we did is we get the people in the ADNI study to donate their spinal fluid. And we've looked at the spinal fluid. And it turns out, we've talked about the A-beta and we've talked about the tau. It turns out that in Alzheimer patients here, the ones in orange, that there is decreased beta amyloid in the spinal fluid, and there is an increase of tau in the spinal fluid. Now this presents a big problem for the Baptists because they would think that beta amyloid was toxic. But actually, there's less beta amyloid in the Alzheimer patients. And what's really related to the dementia is this increase of tau. So this is in a group of comparing Alzheimer patients and controls. Well, this was done in the year 2003, And the Alzheimer's Disease Neuroimaging Initiative came by, and they found the same thing. And they found that if you went from Alzheimer's disease to mild cognitive impairment to normal controls, as you go along here, the tau increases in the spinal fluid. Everybody see that? Okay? Statistically significantly. The A beta goes from 206 to 164 to 143. It decreases in the spinal fluid. The p-tau also increases. And they look at ratios and all sorts of things. Okay, looks pretty convincing, doesn't it? Does anybody believe this? All right, you don't have to commit. We divided it by ApoE genotype. If you look at this specifically for ApoE genotype, you look at the 3-3s here. They do go down a little bit as you go from normal to mild cognitive impairment to mild AD. But the mild AD cases of 3-3 have a higher A beta than the normals who are 3-4. And they change very little bit across this continuum. But the mild Alzheimer's patients with a 3-4 have a higher A beta level than the normal 4-4s. So it actually turns out that these numbers, once you divide them by the ApoE genotype, do not show statistically significant decline related to whether or not you have Alzheimer's disease or not. This is an artifact of the ApoE genotype. The tau, on the other hand, is clearly related to the progression from normal to MCI to Alzheimer's. These are the sorts of traps that we have in trying to understand Alzheimer's disease. People look at one thing, they don't pay attention to the genes, and then they think that the problem is the amyloid, when the amyloid is actually a normal protein in your brain. It's one of the most highly turned over normal proteins in your brain, and it actually helps you remember things. It is a normal memory stimulating protein. Now, some people say it's toxic, and it may be toxic, but there are other toxic things in your body. One of the major toxic substances in your body we know is nitric oxide. Anybody know what nitric oxide does? It relaxes blood vessels. It's essential to relaxing blood vessels. In fact, it's absolutely essential for erections. And Viagra works by stimulating the production of nitric oxide. So a toxic substance sometimes has important roles in the brain or in the body, and amyloid seems to be one of those. And this is just more of the data that, going through the same analysis. I'm not going to expect you to read this, but I have in your handout, I have a list of my top 10 recommendations for preventing Alzheimer's disease. And in spite of what the NIH says, I will stand behind these. I am making such recommendations: maximizing and continuing your education and mental exercises, and your physical exercise, keeping your social networks up, spiritual interactions, continuing to monitor your diet. You talk about a Mediterranean diet, this kind of diet where there's more fish and less meat, and more of certain types of vegetables and less of others, and fresh fruits is good for you. Not being overweight, all of these things have been associated with less Alzheimer's disease. Physically protecting your brain, because we know that head trauma is associated with Alzheimer's disease. Watch your basic medical problems with your clinician. If there's a problem with high blood pressure, we know high blood pressure is related to a substantial increase in risk getting of Alzheimer's disease. We know there are relationships between diabetes and Alzheimer's. And so we think that you should monitor your blood pressure, monitor your cholesterol. If you have elevated cholesterol, you should be on statins, and we think that statins may work, at least in some group of people. We don't know the relationship to ApoE genotype because no one wants to know their ApoE genotype. But it may be very important to know whether or not some people may benefit from, say, statins while others wouldn't. We have to get more into these to study them. The future developments, we have a whole list of different medications that we're trying. We've talked that some of them we're actually trying here. I believe that we have to develop some Alzheimer's disease diagnostic and treatment centers where we can study the people who have the disease. This disease has been studied extensively in rats and mice. We have excellent models of Alzheimer's disease in mice. We can cure Alzheimer's disease in mice. They're excellent subjects. Alzheimer's patients are not as good subjects, and we can't cure Alzheimer's disease in Alzheimer's patients yet. We have to look at the patients. We need to look at the spinal fluids. We need to do more brain scans. We have to get over our problem with genetic testing. We need to get to the point where we can develop cognitive testing on computers so that people can keep a better track of what their memory functions are, as we've shown you. And we have to do better diagnosis and follow it through the autopsy to see what's really happening in the brain. Because as you get older, there's more and more factors that cause dementia. We have to know what Alzheimer's disease is and what the other diseases are, like frontotemporal dementia and Lewy body dementia and all the other things. So there are several different directions that I believe that we need to go if we're ever going to stop this disease. I believe that we've got a good chance of stopping it. If we could understand the genetics more clearly, there's a disease called phenylketonuria, PKU. Even when you were born, you were all tested for this. And if you had it, they restricted phenylalanine in your diet until you were a year old, and then you wouldn't be mentally retarded. And if they didn't do that, you'd be severely mentally retarded. I think this is the level where we need to understand Alzheimer's. We need to know what the genetic factor is, how it's working, and at what age we can make important changes. It may be as simple as a simple medication, because there's several medications I've shown you, like statins, NSAIDs. Some of the antihypertension medications are associated with increased or decreased risk of Alzheimer's disease. We have to know how these things interact with the genotype, and if you have a 4/4 genotype, we have to know how to help you change your lifestyles, your medications in your 20s, 30s, or 40s to prevent Alzheimer's disease. And that, I believe, is where we have to go in the future. So that is my view of the future. Thank you very much for tolerating my presentation. And we have 15 minutes left over for questions before they kick us out of here. Start at the beginning. Okay, so she's asking if I recommend genetic testing to find out what your genotype is. Different organizations have not recommended this at this time. And the reason is largely because they've got no idea how to treat you. But it's a little bit like keeping your head in the sand, because if you don't know what it is and what your risks are, and I'll tell you this, there's a group of people that don't want you to get tested, and that's the insurance companies. Because if you find out, if you have a particular genotype, you're more likely to get Alzheimer's disease, you're going to want to go out and buy long-term care insurance. And they've written papers on this. This is a major downside risk for them if you go out and find this. But what you could do, you see, is you could get your genotype, and it may or may not make any difference to you, but you could go and tell this to your financial advisor. So if you had an ApoE44, where you say, geez, I've got a pretty high chance of developing Alzheimer's disease by the time I'm 67 years old, you'd want to invest in short-term securities, retire young, and have a lot of fun. But if you've got an ApoE23, where you're not going to get it until you're 95 years old, you want to invest in long-term securities, work for a long period of time, and not have any fun. So, your financial advisor will, tell you exactly how you should behave.
If you want to get tested, where can you?
Well, you can get tested, and it's an expensive test, and Athena Diagnostics has a patent on this. And this is one of these things where I hope they break the patent, because I think the patenting is part of the problem here, and Duke has the patent on it, has licensed it to Athena Neurosciences. It turns out that it's more complicated than what I've sort of suggested. There's a 2, the 3, and the 4, and there are things called single nucleotide polymorphisms that distinguish these things. But the thing is this: they've patented the ApoE. The apolipoprotein E gene codes for the production of something called the apolipoprotein E. Okay, so the gene codes for the protein. The problem is, we haven't found any clear relationship between the protein and Alzheimer's disease. Just in the last year, we've discovered that there's another gene right next to the ApoE gene called the TOM40 gene, translocase of outer mitochondrial membrane, for those of you that are interested. And this codes for a mitochondrial protein which is very much involved in energy, and actually has a more likely story to be related to Alzheimer's disease than the ApoE does. And this particular, how that particular SNP is actually available on the 23andMe scan that they'll do for you down here in Mountain View. So you can, for $400, you can have one of these scans of your whole chromosome, of your whole DNA done, whether you give you 600,000, and depending on whether you have 0, 1, or 2 of the SNP that's related, that can give you an idea about what your risk is right there, and it's probably more relevant than the ApoE. Now, this is not recommended at this point. You can do this, but you're sort of operating outside the medical arena at that point. And I'm thinking that this is something that we need to get over. This country, this world needs to get over this O.J. Simpson thing of not wanting to deal with the DNA, and I believe we need to deal with it. But it's very hard for me to tell one person to go how to deal with it. We really need to deal with it as a whole clinical field. Tom 40? Oh, 23andme.com. Yeah, they run a whole scan for you nowadays. Okay, here. Well, let's take, he's interested in what the variation is within an identical group. So the most relevant group that I think are the individuals that have the 4-4. They develop at the earliest, and that's the group I think we should be identifying and figuring out how to treat those individuals. If we could figure out how to treat the 4-4s, I think that would be the biggest advance that we could make in the field. Now the thing is that they don't all develop Alzheimer's disease at exactly 67 years old. The standard deviation is about 10 years. So there is a variability. Now what is the variability? It's like even identical twins aren't exactly the same. I got 2 grandchildren who are identical twins, and they're not exactly the same. Very similar, but you know, there's a whole lot of things that lead to people being a little bit different. Excuse me. It turns out that there's probably another dozen genes that each contribute a tiny amount of variation between individuals. So if you have even identical twins have about a 5-year differentiation of when they develop Alzheimer's disease. They're very much related, but it's not exactly the same date. How many times you hit your head, and a whole lot of other things contribute to this. So as you get older and older, the one thing that's true as you get older is there's increased variability. So that's the best we can do. Well, I wrote a paper on head injury recently, and the one thing that's the clearest about head injury is there's tremendous difference between every head injury. Where it came from, how severe it was, how the person's head, what shape it was, everything else. So it's very difficult to even, to look at head injury as a unique, individual thing. It's not like, either had a drink of water or didn't have a drink of water. It's a complex thing. We know that in head injury there's an increase in both the tau protein and the amyloid protein in the spinal fluid as the neurons are trying to integrate themselves when they've been injured. And we think this puts stress on the whole system and increases the chance of developing the Alzheimer's changes. Yeah. Well, I listened. Okay. The question is, how about hitting soccer balls at age 10? And sometimes I have the unfortunate experience of listening to John Madden as I'm driving in the road. And he says, the old big things nowadays that all the kids are worried about when they're out on the soccer field or the football field is hydration and concussion. So everybody's worried about that now. Is it relevant or is it not? We definitely know that boxers have a substantial increased chance of developing dementia. Soccer players, less clear, but I think there's some people have written some papers suggesting it's a potential problem. I'll give you my bias. I was on the swimming teams when I was in high school and college. I thought that was the safest for the brain. I don't think football is for sure. So those are Lewy bodies, L-E-W-Y. These are particular accumulations of a particular type of protein in the brain that's highly associated with Parkinson's disease. Now it turns out that perhaps as many as half of Alzheimer's patients have accumulation of these Lewy bodies diffusely throughout the cortex. And this is a whole other type of pathology that we think can also lead not just to dementia, but also to a fair amount of hallucinations and other psychotic behavior. And I've been doing my best to figure out Alzheimer's disease. You want to start trying to figure out Lewy body dementia and start figuring out frontotemporal dementia with all the tauopathies associated with it, and Huntington's disease and Creutzfeldt-Jakob disease. There are many different types of neuropathologies that lead to Alzheimer's disease. The discussion of Lewy bodies I'm going to have to leave to the neurologists, a whole other subject, and their alpha-synucleins and all these other things. So there has been tremendous interest in medications to treat Alzheimer's disease. I was just reading about a drug called Rember, R-E-M-B-E-R. It's methylene blue. That was the huge interest in the 2008 International Conference on Alzheimer's Disease. And everybody was interested in this. And this was like the big splash of the meeting. At this point, everybody's given up on it. The year before, it was Dimebon, the special antihistamine that had come from Russia. And, 2 months ago, Medivation in San Francisco had the stock going about, up in the 40s and 50s, and the bad news came out about the drug, and the stock went down now to 10. There has been, I've been studying this Alzheimer's disease since 1978, and basically, there's the treatment of the month club. I mean, I've heard so many treatments come and come and come, and they never pan out. Ginkgo biloba, is the solution to all of man's problems. Vitamin E, going to solve everybody's. Good for your sex life, but probably not your Alzheimer's disease. There are so many of the drugs, and people desperately want to find the drug that's going to treat Alzheimer's disease. And my opinion is, and I've had this opinion for a long time, and it's made me an outcast in this field, is that we need to understand the disease, and we need to understand the cause and effect relationships, and we need to understand the genetics before we start developing treatments. And so I have my 10 recommendations that I've given to you. They're basically healthy living situation things, but all these different medications. So the major drugs that are used now are drugs like Aricept and Remenil and rivastigmine and galantamine, which actually now is over the counter, or now it's off generic. It's now generic, so it's off patent and is much cheaper. These medications probably do slow down the Alzheimer's process a little bit. They are not recommended for mild cognitive impairment, but once you reach that transition from mild cognitive impairment to dementia, they do seem to slow it down and delay nursing home placement. And I talked about that before. In 1981, I published the first double-blind study of a cholinesterase inhibitor to treat Alzheimer's disease, and these are all cholinesterase inhibitors. So I published the first study of this whole class of drugs in the field based on a study we did in 1978, 1979. My feeling at that time, and it's still the same, is we've got to figure out what the disease process is before we develop treatments. And I realize that is discouraging, but we need to develop a billion-dollar center here at Stanford to understand what Alzheimer's disease is, not a center to develop new treatments. Once we understand what it is, the treatments will come easily and obviously, and quickly, just like phenylketonuria. Once they understood that, it took about a year or two before they figured out how to prevent phenylketonuria 100%. And we need to get there as soon as possible. But we're not going to get there by the drug companies investing billions and billions of venture capital dollars in a bunch of whims. And the people that believe, the Baptists that believe that beta amyloid is everything, I don't think they understand how the disease process is working at all. And my apologies to Dr. Jagus yesterday, who said he believed in the beta amyloid theory, but I don't. She says the worst case of Alzheimer's disease is when they lose all their memory. And that's basically what happens at the end, is they lose all their memory. But it's a progressive problem. Sir?
Does lithium fall into that same supplement that you...
I was very interested in lithium for a while, and there's still some interest in it, because it seems that lithium might be one of the few medications that we have that will prevent the hyperphosphorylation of the tau protein that I've talked about. The problem is that when they've looked at a whole lot of people who have taken lithium, like people with manic depressive illness, it doesn't seem to prevent Alzheimer's disease. Very hopeful. We're still hoping that maybe we should restudy it and find, but I'm not hopeful.
You said that the visual system was impacted least by Alzheimer's. Does that hint what makes the visual system so robust?
I don't think I said that, and I know many things I say are easily subject to a misinterpretation. And I apologize for probably several hundred misinterpretations.
The diagram is blacked off.
Yes. What I said is the primary visual cortex. The primary visual cortex is very much protected from Alzheimer's disease. The primary motor cortex is very much protected. The primary sensory cortex is protected, and the primary auditory cortex is protected. These are primary regions of the brain that process information at a very low level. They reach the critical periods very soon after birth. The connections are made, and they do not change throughout the course of life. It is the areas of the brain that are just back in the temporal lobe there that are forming new connections the most often when you learn new things that are the most vulnerable to the Alzheimer's pathology. The areas of the brain that are involved in forming new memories, whether they're visual, auditory, or whatever, are the most affected. Now, there's been a big interest on campus in something called the default mode network. And Dr. Mike Grecius here in neurology has looked and see if you go into an fMRI scan or MRI scan and they do these analyses, they show that if you're just sitting there, just sort of, listening and with your eyes closed, that the area of the brain that's activated is very similar to the area of the brain that's most affected by Alzheimer's disease. I think that this is sort of an artifact that it's the perceptual areas of the brain that are sort of, paying attention and ready to encode new information that are most affected. It is not the area of the brain that when you're fantasizing about things that's affected. It is specifically the memory mechanisms in your brain, the areas of the brain that are most involved in forming the new connections all the time that are most affected. Did I clarify that? Okay, sure? When I first developed this test, I developed several versions of it. So that we had words, black and white words. We had line drawings in black and white of things that were very easy to name. We had line drawings in black and white of things that were impossible to name, like geometric shapes and things. And we had pictures like this. What do you think the difference is between them all? The pictures are more fun to look at, which to me is critical if you want people to take the test a second time. I don't know. I first noticed this problem when I was about 23. How much time? It's 9 o'clock. They're going to kick us out of the room. They'll give you the test back. As unfortunately, I'm going to tell you a long story about aging and how I think it's a bad idea, but on the other hand, I don't have a better alternative. As you age, your systems deteriorate, everything deteriorates. The systems in your brain deteriorate. They don't transmit information as quickly anymore. And it gets harder and harder to sort of retrieve those things. There's more and more information to retrieve them from, but things aren't laid down as well as you get older and older. But on the other hand, you have more expertise. So you're much better able to fake it so they don't realize you can't remember their name. Okay, thank you so much for your attention. I can take other time.
For more, please visit us at stanford.edu.